Good morning, everyone. Welcome to Pediatric Grand Round. Today it's our great pleasure to welcome Dr. Debbie Ann Shirley from the University of Virginia as our invited speaker. Dr. Shirley hails from UVA currently, but originally from Jamaica. Yay! She trained at the University of the West Indies, completed her pediatric training at Children's Hospital of Sinai in Maryland, and her fellowship training in infectious diseases in the University of Maryland. She's been at the University of Virginia since 2013. She also completed a master's in public health at Johns Hopkins University, someplace in between residency and fellowship. She currently serves as the clinical director of infectious diseases and as an attending physician in breastfeeding and newborn medicine and infectious diseases. She has been an invited speaker throughout the Commonwealth. She has multiple publications to her name, journals, abstracts, and poster presentations. She's also co-written 2 chapters on cholera and amoebiasis in Infectious in Textbook of Pediatric Infectious Diseases. She's a member of the Zika Task Force and has been involved in numerous clinical studies in the past, now more focused on clinical medicine. Please welcome Dr. Debbie Ann Shirley.
Can everyone hear me? Okay, perfect. So it's a pleasure to be here today and to talk to you a little bit about travel medicine. I think it's the perfect time of year to actually talk about this because summer's around the corner, and many of your patients and their families are actually going to be making travel internationally for the summer. I think now more than ever, flights are cheaper and it's more accessible to travel internationally, and so more than ever, we do find that patients, including young children, are traveling internationally, whether for vacation purposes, for work purposes, like accompanying their parents for work, going on pilgrimages, doing humanitarian services, or just visiting friends and family. And it can be a very fun and exciting time, but you can also develop illness while you're traveling or shortly after. And so I think it's an important topic for us to think about a little bit, especially this time of year. So I have no disclosures. I will be discussing a few off-label uses of antibiotics and vaccines, but everything that I do recommend is consistent with current CDC guidance. Starting off with a question, what percentage of travelers report some form of illness related to travel? Any guesses? E. Okay, I like that one. E, yes. So greater than or equal to 25%. Depending on which study you use, anywhere from 25% to 1 in 4 travelers up to 66%. So 2 in 3 travelers will develop some sort of illness related to travel. Fortunately, it's usually mild and self-limiting, so things like an upper respiratory tract infection, diarrhea, maybe a little bit of a rash, but occasionally it can be much more severe. About 1 in 300 people who travel internationally will end up being admitted to a hospital. About 1 in 2,000 will end up requiring medical evacuation, and about 1 in 100,000 end up dying. So there is some risk associated with travel. So the objectives of this talk are to describe how to perform a health risk assessment for young travelers, to know key resources that can be used to assist with providing routine office-based interventions, including vaccinations and medications related to travel, to provide anticipatory guidance to avoid travelers' diarrhea, infectious traveling safely with children, and then to recognize illness in travelers returning from overseas. So as I mentioned, more people than ever are traveling internationally. In 2016, about 80 million Americans traveled internationally, and 35 million overseas, so meaning not Canada or Mexico. And about 2.5 million people were traveling with children or were children themselves. So the numbers are definitely going up. So another question for you, what is the most common cause of death for all travelers in developing countries? Good, yes. So it's not actually infection. It is cardiovascular, accounting for about 50% of the deaths that occur, and not necessarily with respect to the pediatric population. This generally older populations, and then followed by other medical causes, and then we have injuries accounting for maybe about 13% of deaths that occur. Of injuries, motor vehicle accidents and drowning are the most common injuries that occur. And infections, thankfully, it's actually pretty rare to die from an infection, but it's the most common cause of illness when you are traveling. So still important to know about, and some of these infections are quite preventable. So what infections are we talking about? So common infections associated with travel would include malaria, traveler's diarrhea, leishmaniasis, rabies, dengue, chikungunya, and Zika, with our arbovirus-associated viruses, meningococcal meningitis, schistosomiasis, TB, and you can get pulmonary TB and also extrapulmonary TB, like meningitis, for example, leptospirosis, polio, yellow fever, measles, Japanese encephalitis virus, and Chagas disease, and many, many more. So another question. You were evaluating MS. He's a healthy 2-year-old boy being seen for routine all-child check. You remember that his mother's a graduate student at the local university and is conducting research on child malnutrition. You casually inquire how her project is coming along, and she tells you that her project's going very well. In fact, next week she will be visiting one of the research sites in Dhaka, Bangladesh for 3 weeks, and she plans to bring her son along with her. What could you do next? Wish them a wonderful trip, give him his second dose of MMR, write a prescription for azithromycin, provide malaria prophylaxis, or perform a risk assessment, offer standard in-house interventions, and focused education before the trip. Yes. So, yes, all of the above, and it leads me into E, which is performing a risk assessment and then offering interventions and education. So this is a structured approach to providing pre-travel consultation, and it's taken from a review article by David Friedman in the New England Journal. So if this is something that you're actually interested in, I'd highly recommend reviewing this article. It's quite comprehensive and well-structured. So the first thing that you do of 3 things is to perform a risk assessment, and basically you're trying to figure out who's this patient, what medical conditions do they have, are they immunosuppressed, what's their immunization status, where are they going, and what kind of activities will they be involved in. And your risk assessment will then inform the next 2 steps. So the next step being standard in-office interventions, and there are 3 parts to this. So the first part is administration of immunizations, and that would include both opportunities to catch up on immunizations and then also considering any special immunizations that may be required because of travel. The second part is to consider whether or not malaria chemoprophylaxis is indicated. And then thirdly, to talk about travelers' diarrhea and how to prevent it, and also to consider whether giving a prescription for empiric antibiotics is indicated. And then the last part focuses on education and a lot of anticipatory guidance. And there's 3 also stages to this. And so the first one would be talking about the risk of vector-borne infections. So not just malaria, but you can get a number of other infections related to bites from mosquitoes and ticks. So talking about ways to prevent bites. And then sort of tailoring to specific travel-related anticipatory guidance. So, for example, if they're going to be traveling at high altitudes, you might want to talk about altitude sickness. If they're traveling with young toddlers or young children, you may want to talk about how to travel safely with them. For older children, adolescents who may be going with a group of other adolescents, you may want to talk about things like prevention of bloodborne and sexually transmitted infections. And then I usually do recommend that tell them about preparing a medical kit with some common first aid things that they have easily accessible to them for travel. So a little more detail. These are some critical parts to performing a risk assessment. And so first you want to know about medical history, including underlying illness, immunosuppression, what medications are they on, their immunization status, allergies, prior travel experience. And then you want to know specifics about their travel, so not just that they're going to Africa, but what country, what city in Africa, and what are the dates of travel. and what sort of things are they going to be doing, because your risks for acquiring infection will differ. So if you're doing adventure travel, going on safari, you may be at high risk for getting bites, for example. If you're going to be at a mass gathering, you might be at high risk for things that are spread by the respiratory route, meningococcemia, and certainly doing missionary or humanitarian work also associated with increased risk of infection. And then you also want to know about accommodations. Will they be at a luxury hotel, which is probably a lower risk situation, versus visiting friends and family? And I wanted to highlight that group because they have particular risks associated with travel. Often these are families who have immigrated from another country, or maybe a first or second generation, and when they go back to visit, they actually have a very low risk of infection associated with travel, so they're less likely to seek pre-travel advice before they leave. They're more likely to travel with children, and they are actually at very high risk for returning with malaria and typhoid. And then there may be age-specific issues to consider, for example, breastfeeding, bottle feeding, risk-taking behaviors, and preconception. So that risk assessment that you do will inform standard in-office interventions. And as I mentioned, there are three parts to that. So first is immunizations, so either updating immunizations or considering specific ones related to travel, malaria chemoprophylaxis, and prevention of travelers' diarrhea. So we're going to go through each of those in a little more detail. And where can you go to figure out which vaccines are indicated, whether malaria prophylaxis is needed, what's the risk of travelers' diarrhea? So there are many commercial websites that you can subscribe to that can give you this information, but also the CDC is a great resource to use. And I think they've done a lot of work to really make this a good site for travelers' health, both for patients who are traveling, but also for providers, and they kind of divide it into those two subsets. And you can actually get a lot of information just directly from going to the CDC travel website. And they also include notices and important things to be aware of prior to travel. So these are the immunizations to consider. So routine and then travel-related would include typhoid, rabies, meningococcal vaccine, Japanese encephalitis vaccine, yellow fever vaccine. And there is a cholera vaccine that is relatively approved, but it's not for use in pediatrics, and it's essentially more for volunteer workers who are going into very high-risk settings with known cholera outbreaks. So going through vaccines in a little more detail, starting with Hep A, which is a routine vaccination for children, but it's also the most common vaccine infection among travelers. And young children tend to tolerate Hep A infection fairly well, but they serve as a reservoir for older children and adults who can become much more sick with hepatitis A. So prevention, as I'm sure you all are aware, is with 2 doses of the Hep A vaccine that are administered about 6 months apart. What is new, and I promised updates to travel medicine, is that within the last few months, the ACIP has come out with a recommendation to actually give Hep A vaccination to infants who are 6 months to 12 months of age if they are going to be traveling to an area where they would be at risk for Hep A. However, until more information is known, it doesn't count as one of their 2 vaccines, and so when they return, you'd still give the routine 2 vaccines for school. The measles, mumps, and rubella vaccine, also one of our routine vaccinations, but sometimes you may need to consider giving either the first or second dose early related to travel. And it's important to remember that measles is endemic throughout the rest of the world, including Europe. Usually we're not as worried about infectious risks associated with travel to other industrialized or very developed countries, but there's a lot of measles in Europe, and so you may need to consider whether it's worth giving early vaccination in this case. And so immunization is typically with 2 doses that are separated by at least 28 days. If you have a young infant who's traveling, so 6 months to 12 months, then you could actually give the MMR early. It doesn't count again because we don't have enough data to show long-term immunity using this, but it's safe and it may provide some effectiveness. The reason we don't give it typically to this age group is because there could still be maternal IgG hanging around that would neutralize the vaccine. So it may not be completely effective, but it may offer some protection for travel. And then when they return, you'd give them their full 2-dose series. And remembering that the second dose can be given as early as 28 days after the first dose, so sometimes you may want to consider giving the second dose earlier than the typical 4 to 6 year age window. And then, of course, also relatively new is the recommendation to give a third dose of MMR for adolescents and young adults who may be going into a mumps epidemic. So typhoid, which is caused by Salmonella enterica, is a foodborne illness that can cause high fevers, and you can develop bacteremia and dissemination and actually become quite sick with typhoid. And the very scary thing about typhoid is that there's a lot of drug resistance that's developed, and so it's become a very, very difficult infection to treat. So prevention is key, and there are 2 vaccines that are available that we can use for typhoid. One is a polysaccharide vaccine, and you can give that to children as young as 2 years of age, and it's a single dose, but you would repeat it every 2 years if they continue to have risk for exposure. And then there's also a live oral attenuated vaccine that can be given, the FDA has licensed it for use in children 6 and above. It's a little trickier to administer in that it's 4 capsules, and because it's a live vaccine, you have to refrigerate it, and you have to take it on an empty stomach, and you can't eat 2 hours after. So there's a little bit of planning that comes along with taking it. Sometimes you can have a little bit of mild diarrhea or stomach upset associated with it, but immunity tends to last longer, and you could redose every 5 years if there's ongoing risk of exposure. So rabies, so if you are bitten by an animal, typically post-exposure prophylaxis consists of giving rabies immunoglobulin and either 4 to 5 doses of the rabies vaccine. However, if you're traveling, especially in several developing countries, there may not be ready access to this if you're bitten by an animal. So you have to consider that before traveling. And so you can consider actually giving pre-exposure prophylaxis, which helps to simplify the post-exposure prophylaxis in that you no longer have to give the immunoglobulin, and that sometimes simplifies actually finding the appropriate treatment for an animal bite. And so pre-exposure prophylaxis is 3 doses of the rabies vaccine. It's given at day 0, 7, and 21 to 28 days, which means you have to have sufficient timing prior to travel. Ideally, when you're talking about travel, you'd like to see patients at least 4 to 6 weeks before they travel to accommodate for things like this. So you'd give those if they're going to be traveling to long-term or short-term if they're going to be in a high-risk situation. We consider young children to be at high risk for rabies just because smaller size, less intimidating maybe to smaller animals, more likely to try to interact or feed animals. And so whether or not you do give the rabies vaccine, it's important to actually talk to your patients and tell them when they're traveling not to pet animals, not to try to feed animals. Every few months we always get a call about a child who's bitten by a monkey when they travel internationally. So I think monkeys are adorable and cute and want to play with them, but they are wild animals, and you want to make sure kids know not to try to interact with them. And also young children are at high risk for being bitten in the face and the neck because of their short stature, and as you know, that shortens the incubation period for rabies. So it really puts that time pressure on you if it happens. So yellow fever vaccination. So some vaccines are required for travel and some are recommended. There are 2 that can sometimes be required, and of those, yellow fever is one. And it's required for travel to much of South America and sub-Saharan Africa. And you may be aware of a large outbreak that's currently going on in Brazil with yellow fever. And since 2018, there have actually been 10 travelers who have acquired yellow fever from traveling to Brazil, and none of them were immunized and 4 have died. So it can be a fatal infection. And some countries are trying so hard to keep yellow fever out of their country because they have the vector, and so they actually require you to have proof of immunization if you're coming from an endemic area prior to being allowed into the country. And once you do get the yellow fever vaccine, it gets stamped, written up in a yellow card that you can travel with in your passport and show them when you arrive at immigration. So the yellow fever vaccine is a live attenuated vaccine. It's indicated for children 9 months and above. There is a precaution in breastfeeding mothers because there have been case reports of breastfeeding mothers receiving the yellow fever vaccine and transmitting yellow fever to their children that way through the breast milk. It used to be that we'd have to give a booster every 10 years, but now immunity is considered to be lifelong, so it's 1 dose. And some risks associated with the vaccine include yellow fever-associated neurotropic disease and yellow fever-associated viscerotropic disease. And basically, because it's a live virus, very, very rarely it can revert to wild type and actually cause disease in your patients. And this is why you usually want to have a very good indication to give it. And so patients who have this can develop encephalitis, liver failure, and can become quite sick. And risk is associated with extremes of ages, especially being 60 years and above. And then another update, I think this might be my third update, is that the yellow fever vaccine is currently on shortage in the U.S., and so there is a European version of the yellow fever vaccine that has been made available by the FDA under an IND for use until our stores are replenished, and it's anticipated that by mid-2019, so maybe around summertime, we will have the yellow fever vaccine available, but you can get the Samaril at select sites throughout the country if you need it. So meningococcal vaccine, so there's a meningitis belt along sub-Saharan Africa, and especially during the dry season, there's an increased risk of developing or acquiring meningococcemia. And it's recommended for travel to sub-Saharan Africa, and it's required. So this is the second one that may be required for travel. And if you're going for a pilgrimage, for example, to the Hajj or Umrah, then it's actually required before you are allowed to enter. And we use the same two vaccines that are commercially licensed. So there's Menactra and Menbio, and you go by the age and what you have available for the schedule. It used to be that along the meningitis belt that we were seeing a lot of the serotype A, and now that's actually a vaccine that's being given to, in many countries in Africa, the epidemiology is changing, and now we're seeing more C and Y. So that's why you'd want to give the vaccine that protects against ACY and W135. There's less of a risk with meningitis B, and also it's not approved for use in kids under the age of 10, so that's not routinely given for travel. So Japanese encephalitis is an infection. It's a virus. It's an arbovirus that's endemic in rural Asia, associated with being near rice paddies and pig farms. It's rare but unpredictable in terms of the risk for travelers. And there's a vaccine available, and it's recommended if you're going to be staying long-term in an area that is endemic for Japanese encephalitis, or short-term but very high-risk situations. So you're going out into a very, very rural area where there's a higher chance of being bitten by one of these mosquitoes. And vaccination is with 2 doses of the Japanese encephalitis virus. The dose depends on your age, and it can be given to infants as young as 2 months who are at risk. So dengue vaccine is actually not a traveler's vaccine, but because it's a relatively new vaccine that's come out, you may have patients who are asking about it, and so I did want to let you know a little bit about it. And so there is a newly available 5 tetravalent attenuated dengue vaccine, and it was being targeted for areas that are endemic for dengue. So a little information about dengue. There are 4 serotypes, and you develop lifelong immunity to the serotype that you're infected with, but there's no cross-protectivity. And in fact, if you get infected a second time with a different serotype, you can have sort of exaggerated immunologic response, and you can actually become quite sick with your second dengue infection. And so it becomes a problem with the vaccine, because if you give this live vaccine and you develop some immunity, it's possible that the second time that you're exposed to the vaccine, you may develop an exaggerated response, and indeed that has been a problem with the vaccine. And so if for countries who are giving it, they should really be targeting people who've been infected with dengue, which becomes problematic because in resource-limited areas, how do you screen effectively for this? But it's not a traveler's vaccine. It's not available in the U.S. If patients do ask you about it. Okay, so those are vaccine updates. Moving into malaria and malaria chemoprophylaxis, about how many cases of malaria do you think are reported in the U.S. each year? Very good, 1,500 cases, exactly. But a lot of these are preventable with extra precautions in the use of chemoprophylaxis. So it's important, even if your patient is going to be on malaria chemoprophylaxis, to still try to protect against bites, because there are other things that they can acquire through bites from mosquitoes and ticks, including dengue, chikungunya, Zika, Japanese encephalitis, leishmaniasis, and a lot of rickettsial diseases. And so talk to them about covering their skin, using insect repellent with either DEET or Picardin, using nets, and they can be impregnated with permethrin. Sometimes being in an air-conditioned room also helps a little bit, and doing tick checks afterwards, and then malaria prophylaxis if it's indicated because of travel to an area that's endemic for malaria. So these are the options for prophylaxis in children. There are basically 4 options, and I would say of these, atropine proguanil, otherwise known as Malarone, would be the preferred choice when possible. It's an adult dose, but also it comes as a pediatric tablet, and it's scored so that you can break it if you need to. And there's weight-based dosing that's readily available either on the CDC website or in the Yellow Book. And so if you're using atropine proguanil, you have to start 1 to 2 days before they arrive in the area that's endemic, and continue it for 7 days after. And it's actually very well tolerated. Occasionally you can have some nausea or diarrhea and rash, but in general it's very, very well tolerated in children. Doxycycline is another option, especially for children older than the age of 8. And you'd start this 2 days before, but you have to continue it for 28 days after returning from that endemic area, which often patients will forget to do. And common side effects, we know well for tetracycline, the photosensitivity, which may be important if they're going to be out in the sun a lot, can cause that esophagitis, yeast infections, and C. diff infection. Methylquin is another option. There is more toxicity associated with it, in particular neuropsychotropic effects, and it can also prolong the QT. And so for this reason, maybe it's not as preferred as atropine proguanil. If you do use it, it is weekly dosing. There's also pediatric dosing, weight-based dosing available, and you would start it 2 weeks before travel. And again, you have to remember to continue it for 4 weeks after returning from that endemic area. And then chloroquine is an option if you are going to an area that does not have chloroquine resistance, which for all intents and purposes is the Caribbean and Central America. And you start that 2 weeks before and continue it for 4 weeks after. Sometimes it can cause some itching, vomiting, headaches. So that's malaria prophylaxis, and then moving into traveler's diarrhea. So for prevention of traveler's diarrhea, hand hygiene is key. So washing hands with soap and water. Even if the water is contaminated, it's better than not washing at all. And then using hand sanitizer if water is not available. And then for young children, you may have to remember about keeping bottles and toys and pacifiers clean, because of course they're constantly putting things in their mouth. Children are definitely more prone to developing dehydration from diarrhea, and so when drinking water, ideally you'd want to use bottled water or disinfect your water, which can usually be achieved through boiling. And when eating foods, you want to choose foods that are well cooked and hot to decrease the bacterial load. as opposed to salads and raw vegetables where it may be difficult to actually wash them well enough to remove that bacterial load. Avoiding unpasteurized dairy products, street vendors, and also, like, if you go out to a restaurant, remembering that tap water and ice in that drink may be contaminated, and so being wary of that. And it's great to have prepackaged cookies and crackers and crisps to have for children, especially young children, for snacking. So if you do develop traveler's diarrhea, it's most likely to be bacterial, which is a little bit different from our epidemiology, where it's most likely to be viral. So for that reason, if it's anything more than mild to moderate, you could consider giving antibiotics after you rehydrate. And so typically for children, that is azithromycin, and so you can give a prescription for azithromycin. If it has to be liquid, then you tell them not to reconstitute it when the pharmacist dispenses it. But the key to diarrhea management is always rehydration. You could consider using bismuth or loperamide, but I personally tend to try to avoid it in pediatrics because of the side effects. So management of traveler's diarrhea is similar to management of diarrhea, where after every stool you try to give oral rehydration fluids, and then if they develop very severe diarrhea, so just profuse diarrhea or bloody, or they have a high fever, ideally they should seek medical care. And then they have the azithromycin, 10 mg per kg. So it's the dosing is a little bit different than what we usually use for like a community-acquired pneumonia, in that you give a higher dose for 3 days. So it used to be that we would give prescriptions for diarrhea and tell you at the first sign of diarrhea you take it, but actually there is some risk also associated with that, and in particular the acquisition of resistant bacteria. And so if you take just one course of antibiotics when you're traveling internationally, the odds of acquiring a resistant bacteria are sixfold higher. And you have a 12% chance of passing that along to household members when you return, and you have a 12% chance of being colonized at 1 year. And that's why you would want to tell patients not to necessarily take it for mild symptoms that are likely to resolve on their own or can be managed with rehydration, and to really save it for the more severe presentations of diarrhea. And then moving into the last arm of your pre-travel consultation, which would be providing focused advice. And so if patients are going to be traveling to higher risk settings, you may want to discuss whether it's worth purchasing additional medical insurance to cover the cost of hospitalizations or evacuations if they're going into higher risk areas, and to kind of have them even start to think about where's the nearest hospital, where would they go if they were sick, and to be aware of travel notices. And you can actually, anybody can sign up for the Smart Traveler Enrollment Program that's run by the government, and they can receive like text messages and alerts about safety concerns related to travel. So traveling with children, it is recommended that children travel in their own seats with a child restraining seat. And so if they're less than 20 pounds, that would be rear-facing, and 20 to 40 pounds forward-facing. However, it's not required by airlines, and so for young children less than the age of 2, they're actually parents are actually allowed to have the child on their lap, which can sometimes be a big way to save on costs for families, but also is more dangerous. And educating about how to deal with borrowed trauma, especially for young children who can have a lot of pain associated with the changes in pressure with cabin ascent and descent. And so just finding ways for them to chew or swallow usually helps a little bit with that. Making sure that there's entertainment, and that they think about where the child will be sleeping, and making sure that they have enough food for the trip. And then if you have a child with lung disease, it may be important to actually have them see a pulmonologist for hypoxia tests, because they may become hypoxic during travel, and so the flight, and so you may need to actually travel with oxygen in that case. So environmental precautions. So remembering that graph where we saw that injuries account for 13% of deaths, and so continuing your anticipatory guidance about using seat belts and car seats, protection against prevent heat stroke and sunburn, so protective clothing, hats, sunscreen, avoiding extremes of heat and cold. If they will be traveling to heights above 200 meters, then considering a prescription for acetazolamide. And then drowning was the second most common cause of injury, so just remembering to supervise children when they're around water, and also there can be a risk of infection related to swimming, so things like schistosomiasis and leptospirosis, so just being aware of any health advisories about swimming in that particular body of water. And then children should always wear shoes to prevent worms from boring through the skin in their feet. So for older children, you may need to discuss the risk of sexually transmitted infections, and unfortunately this does happen where kids do engage in unsafe sexual practices during travel and come back with sexually transmitted infections. And their parents may not talk to them about it, their counselors may not talk to them about it, so it might be our job to talk to them about prevention of these before they travel. And then, as I mentioned, it's always a good idea to have a little bit of an emergency kit available, and in that kit you might want to stock medical records if needed, immunization cards, making sure that you have enough prescription medication to last for the trip and maybe a little extra in case there are any layovers or delays, and then common over-the-counter medications, because when you're traveling, if you're going to a country that has another language, you might walk into a pharmacy and not be able to identify any of the common medications over the counter, or maybe in a different language, so it might be just safer to travel with your own bottle of Tylenol or ibuprofen, packing oral rehydration solution, sometimes normal saline drops for little children who develop upper respiratory tract infections, definitely an EpiPen and antihistamines if there's a risk of allergy, and then some common first aid things, usually worth the while. So back to that case that we had mentioned at the very beginning. So you perform your risk assessment for MS, and you confirm that he's a healthy boy, with, not on any medications, no known allergies. His immunizations are up to date. And in addition to going to Dhaka for about 21 days, his mom also plans to take him to Mangalore, which is where she's from, for 10 days to visit family. And they'll be on the beach there, and the family will be preparing meals. So based on your risk assessment, you end up recommending that he receive the Hep A vaccine number 2, his second dose of MMR, a little bit earlier than the 4 to 6 year window we typically give it. And you do recommend the typhoid vaccine because he's 2 years old. And because he's going to Mangalore, which is endemic for malaria, you then offer chemoprophylaxis, and then you talk to them about avoiding mosquitoes, to prevent dengue, chikungunya, to avoid animal contact, to exercise caution when using, when ingesting food and water, and then you also warn about TB risk factors because he's going to 2 TB endemic areas. You suggest that when they come back within a few weeks that he receive a TB screen to screen for latent TB. So that's a little bit about pre-travel, and so I wanted to spend the rest of the time talking a little bit about post-travel, and of course this is a very extensive topic, but just giving you a couple of things to think about when you see patients who are returning from travel with illness. Often their symptoms can actually be divided into a nonspecific febrile illness or a respiratory illness, a CNS illness, a diarrheal illness, or a rash. And there are well-established differentials for each of those categories. And probably one of the most important things that I'd like to emphasize is just asking about the travel history when you're evaluating patients with fever or illness that you don't have an obvious answer for. I can't tell you how many times I've been asked about helping with the differential for fever in a child without an obvious focus for the fever, and the travel history hasn't been asked. Sometimes I've even heard things like, I don't think that they look like they have enough money to travel. With that very same comment, the day after, I received a call from that same provider about how to treat for malaria because the child did indeed have malaria after traveling to West Africa. And for some reason, families may not think to volunteer this information to you, maybe just because of a lack of perceived risk or a lack of understanding of the association with travel and illness. And so it's up to us to actually ask. Probably one of my favorite stories of all time was when I was a fellow. I received a call from one of our pediatric residents, and she was doing her surgery rotation. And so they had evaluated a young boy with severe abdominal pain and fever, and his symptoms were so concerning for acute appendicitis. He's actually being taken to the OR without imaging. And our pediatric resident was busily trying to get the history, as they're wheeling the patient away, and she asked about travel, and it turns out that they had from Guatemala. They call and said, "Is there anything we need to be worried about?" And I was like, "Yes, there are things you need to be worried about." And this is another case of malaria. And so just by asking that question, he was spared a surgery that he didn't need. So, yes, and so when you are evaluating a patient who's traveled recently, important things to ask about in your history are very, very similar to your pre-travel risk assessment, in that you want to know about their past medical history, their medications. Did they seek advice before? Did they get immunizations before that were recommended for travel? Were they on prophylaxis? Were they adherent to prophylaxis? And you want to find out about their accommodations and what sort of activities that they were partaking in to try to figure out what their risks for certain infections are. So I'm going to go through a couple of cases to help exemplify some of this. And so starting with a 16-year-old female who presents with fever for 8 days, chills, arthralgia, neck pain, headache, fatigue, and decreased oral intake. She had traveled to Uganda for about 2 months and had returned 6 weeks ago, spent some time volunteering there. She did take malaria prophylaxis with doxycycline, slept under mosquito nets. She drank filtered water from a well. They pasteurized milk by boiling. And she did swim in lakes there, and she did admit to walking barefoot outside. And she was exposed to a number of animals, including chickens, dogs, and cows that were nearby. She was seen the day prior in the emergency room, and they tested for Lyme, Hep A, and mono. And those were the serologies for those were negative, and they have a blood culture that's pending in their state. So when you look at her, she's febrile. She's non-toxic but tired appearing, and she's icteric and has a grade 1 out of 6 ejection systolic murmur. White cell count is 6.7. Hemoglobin is 11.3, which is actually a decrease from the day before, and her platelets are low at 79. Her sodium is low at 131, and her total bili is high at 4.5, and her AST is 64. So, is there any other information you'd like to know, or do you have any thoughts or differentials about what could be going on?
Was she on any kind of prophylaxis during the time that she traveled?
So, great question. And she was taking doxycycline during travel only. That's correct. Yes. So I think what I'm hearing are concerns that this could be malaria, and that should definitely be number one on your differential for a patient returning with fever. And this is your differential for nonspecific febrile illness, and malaria is at the top, followed by dengue, typhoid or enteric fever, mono. So we think of rickettsia as being sort of endemic to our area, but there are actually a number of different sort of rickettsial illnesses that you can acquire around the world. African sleeping sickness or trypanosomiasis, acute HIV infection, leptospirosis, Ebola, and viral hemorrhagic fever. But don't forget they can also have common causes not associated with travel, just like pneumonia and a UTI. But malaria would be the most common cause of acute undifferentiated fever in people returning from travel to sub-Saharan Africa. And that was her smear. So you can see the ring form of the parasite. And just a little bit about malaria. So there are 4 main species that infect humans. There's Falciparum, Vivax, Ovale, and Malariae. The incubation period, especially for falciparum, is about 7 to 30 days. but actually patients can present weeks to months and even years if they acquire Vivax or Vali, which can have a liver stage that stays dormant in your liver and reemerges. So commonly patients will present with fever, malaise, nausea, emesis, abdominal pain, and diarrhea. Spleen can be enlarged. Some clues that you can find on your labs would be anemia, thrombocytopenia, or an indirect hyperbiliary. And you should consider in any patient who's traveled, even if they were on prophylaxis, because one, prophylaxis is not always protective. Two, patients may not be completely adherent, and even if you miss a dose, that's enough to develop malaria. And then patients have to remember to continue it for the tail end after returning. The diagnosis is with thick and thin smears, and we also have PCR diagnosis that's become so helpful because you do need a little bit of expertise to be able to identify the parasite. And treatment would typically be with atovaquone proguanil, so Malarone, or with one of the newer artemisinin-based regimens that are available. And patients can become quite sick and die from malaria, and complications would include severe anemia and also cerebral malaria as the parasite starts to adhere to the endothelium and clog up circulation. The second case, the 12-year-old male who's traveled to Mexico who presents with 3 days of fever, up to 104 upon return. He's also not feeling well, not eating well. He complains of leg pain and retroorbital eye pain, headache, and diarrhea. While traveling, he stayed with his family, which was in a very rural area, and he was exposed to several animals, including cattle, chickens, cats, and dogs. He did consume homemade or unpasteurized cheeses, and he drank well from local water from a local well. He played soccer without his shoes, swam in local rivers. On exam, he had a temperature of 100. Heart rate was 106, respiratory rate was 26. Blood pressure was 119/65. He was tired. He had injected sclera. He endorsed pain with eye gaze. He had a very faint blanching erythematous, that should be papular rash on his trunk. And his white cell count was low at 1.4, hemoglobin 13.3, platelets 153. And he had a malaria screen that was negative, and he had a monospot that was negative, and a urinalysis that showed small ketones. So, any guesses as to lepto? That was definitely on our differential. Any other thoughts for differentials?
Dengue.
Hep A?
Dengue.
Oh, dengue, yes, definitely. So dengue would be high on this differential, especially with the rash and his blood cell abnormalities. So this is your differential for a patient who returns with fever and a skin rash within 2 weeks of travel. So dengue should be at the top of your list. Malaria typically does not cause a rash. So dengue, and whenever you say dengue, you can probably just say dengue, chikungunya, Zika, because they're all mosquito-borne infections, and they share very similar epidemiology and overlapping clinical presentations. Could also be measles, varicella, rickettsia, typhoid, parvo, mono, and acute HIV. In this particular case, we did serology in addition to looking for several things like leptospirosis, we did serology for dengue, and we found the dengue antigen, which we see with early dengue, and so this was a diagnosis of dengue. So dengue is the most common systemic febrile illness in travelers returning from tropical areas such as the Caribbean, Americas, and Southeast Asia. As I mentioned, there are 4 serotypes. The incubation period is short, so 5 to 7 days. So you wouldn't necessarily think about this like 3 months after returning, but this is like shortly after returning, and you can develop fever and severe pain. That's why it has the name breakbone fever. They can have rash, leukopenia, thrombocytopenia, and they can actually become quite sick. And the important thing to remember is they can develop complications after the fever disappears. So typically, we associate effervescence with improvement, but this is when you have to watch them more closely. And warning signs for severe dengue would be decreased platelets and an increased hematocrit, which are signs for capillary leak. The diagnosis is with serology, and there's also PCR and an antigen test that you can use. And there's no treatment specifically for dengue. It's supportive, but it's important to remember to avoid NSAIDs and aspirin. They increase the risk for bleeding from severe dengue. Okay. So my third case is a 7-year-old who had received a kidney transplant 3 years ago. that was complicated by antibody-mediated rejection. He is on immunosuppressive medications with tacro and mycophenolate, and he presents with diarrhea for 2 weeks, dehydration, an elevated tacrolimus level, acute renal injury, and this is all happening after returning from a trip to Guatemala. And so typically, as I mentioned earlier, when patients develop diarrhea related to travel, it's often bacterial. It could also be viral. And then if they have sort of delayed diarrhea or prolonged diarrhea and they're seeking attention upon returning, so meaning that they probably had it for at least a week or two, then that's when we see parasitic infections becoming more prominent, like Giardia, entamoeba, and cryptosporidiosis. And that's actually what he ended up having by community GI-PCR. So this is a common protozoal parasite acquired fecal-orally when you ingest the cysts. It tends to cause self-limiting diarrhea in immunocompetent hosts, but immunosuppressed hosts. So patients with HIV, AIDS, or transplant patients can just have very severe prolonged diarrhea and become quite wasted from this infection. Diagnosis is with a stool PCR, but there's also an antigen detection test. And usually the treatment is to lower your immunosuppression, or if it's HIV, AIDS, then to start antiretroviral therapy. And then my last case is a 4-year-old who traveled to Belize and presents with 2 chronic ulcerative lesions on his right upper extremity, initially thought to be infected insect bites. So this is one of those, either you know it or you don't. Are there any guesses as to what this is? Yes, very good. So this is leishmaniasis. And so cutaneous leishmaniasis is caused by a protozoan parasite, and it's transmitted through the bite of a sandfly. And there's Old World and there's New World strains, just basically depending on what part of the world you acquire it in. It starts off as a tiny little papule that becomes a plaque and then a painless ulcer with a raised border and a central crater. Usually the way I think of it, if it looks like a mini cheese pizza on their skin, then that's usually how I make the diagnosis of leishmaniasis. But you confirm it with using culture and PCR that you send off to the CDC. And the treatment can be quite complicated. So it's probably best to discuss it with somebody who has experience with treating leishmaniasis, but there are options for systemic treatment, which could be oral or systemic, both with their own toxicities. Sometimes there can be local therapies that you use for very, very small lesions, and sometimes you can actually just watch and wait. So here are some resources if this is an area of interest to you, and especially if you are having to deal with returning travelers, then a great review article about the approach to fever in the New England Journal, I left there too. And we do have a young travelers clinic at UVA, so we do offer pre-travel consultations, especially for patients with underlying complicated medical illnesses or immunosuppression, and also for post-travel advice if you need that as well. We're definitely more than interested and happy to help. So I was asked to leave with 2 MCQs, and so here they are. During a routine well-child check, the father of a healthy 7-month girl lets you know that the family will be traveling to Ghana in 2 weeks. They will be staying there for 2 weeks, and the infant is up to date on her 2, 4, and 6-month immunizations, including receipt of 2 doses of the influenza vaccine. Which of the following would be the most appropriate vaccine recommendation to make for this infant? So the options are MMR and yellow fever, or MMR Hep A and the meningococcal vaccine, or inactivated typhoid, MenB and the yellow fever vaccine, or the live typhoid vaccine, the meningococcal, and the yellow fever vaccine. Well, if I was B, okay, if I were seeing this patient, I would recommend B too, exactly. So the MMR would be early, right, but that's okay. It would be safe to give. It just may not be as effective if you give it less than a year, but they're definitely going to be traveling to an area that's at risk. Hep A, she's also at risk for that, and because Ghana is in the sub-Saharan, meningococcal belt, we want to give her the meningococcal vaccine. Okay. Second one. 9-year-old boy presents to the emergency room with progressive worsening headache over the past 2 weeks associated with fatigue, photophobia, nausea, and emesis. On exam, he's febrile with a stiff neck. His chest X-ray is clear. His CSF shows about 1,000 white cells with a lymphocytic predominance. His protein is elevated at 220. His glucose is low at 6. The gram stain did not show bacteria. He started on vancomycin and admitted to the PICU. His head CT shows hydrocephalus, and an EVD is placed emergently. And you learn that he visited Mexico 3 months prior. He was exposed to goats, cattle, pigs, and dogs and received several bites. So in addition to treatment of bacterial meningitis, which of the following would you consider empiric treatment of? Did I hear C? Very good. Tuberculosis. So this is a classic presentation for tuberculosis with the hydrocephalus and the CSF profile. And so in this case, you would go ahead and absolutely consider starting TB treatment. Okay. And these are my 2 little international travelers. Any questions?
Oh, hang on a second. Hang on.
The traveler's
Net.
with the 0.5 permethicillin, is that readily available, like on Amazon, to buy?
Okay, so that's a great. Where do you get these nets?
Yeah.
So that's a great question.
The pre-treated nets.
Yep, the pre-treated nets. I have never checked Amazon personally, but I wouldn't be surprised if you could find those on Amazon. But usually they're also locally available as well. So.
One question I have is about the recommendations for travelers' diarrhea. Never quite understood that, because here in the U.S., if someone has bacterial enteritis, you do not empirically start them on antibiotics. We don't slow down their gut by giving them an anti-motility agent like loperamide. In business, subsalicylate has aspirin in it, and we don't give that for children. So those 3 recommendations have never quite set with me. Could you comment on that?
Sure. So recommendations for travelers' diarrhea. And so I agree, the management is quite different for patients who are traveling versus patients who have not traveled and present with acute diarrhea. And so I agree that there are concerns with using loperamide and bismuth for children. And so I'm very, very cautious, and typically I don't recommend using them for those 2 risks. For the antibiotics, so we know that epidemiology in the U.S. is usually viral, and then after that, bacterial is possible. And we don't also rush to treat bacterial causes just because we know some are self-limiting, some may not benefit from antibiotics or potentially could even be harmed with using antibiotics. But we have access to diagnosis and actually trying to figure out what the bacterial cause is so that we can make a more informed decision. For patients who are traveling, they don't always have access to that sort of medical care, and so it's really kind of weighing risks versus benefits and the possibility that they have something like enterotoxigenic E. coli, which is way, way more common than what we see in the U.S. and is readily treatable by antibiotics. But you're right, there could be some harm. It may not be effective. There could be some harm with just using empirically, but it's sort of weighing the risk versus the benefit. And so at this point, the benefit is towards giving for more severe forms of diarrhea.
I guess I think I have the last question. So, Deb, thank you for a wonderful presentation and really gave us a lot of information. My last question is the use of multiple vaccines in 1 or 2 visits with children, given a lot of controversy in our country right now concerning vaccinations. Do you ever have any issues with giving multiple vaccinations in such short periods of time?
So that's a great question, very relevant for the sort of problems we're seeing right now with vaccine hesitancy. I think that probably I'm seeing a very select population in the travel clinic and patients who and families who want to prevent infections as much as possible. So I would say in general it's not a problem, but maybe if you're talking about this with your general pediatric patients, there may be more hesitancy to using. It's totally fine to administer multiple vaccines at the same visit. There are a couple of things that you do have to be cautious about, and the same things like you wouldn't want to place a PPD shortly after giving a live vaccine, for example, or if you are giving the live typhoid vaccine, some of the antibiotics that you give for like malaria prophylaxis actually could kill the vaccine. There are a few things that you have to consider about simultaneous vaccines, but in general, it shouldn't affect their immunogenicity or safety. So definitely recommended.
Thank you very much. I think that is our time. So.
Thank you.